shut down way back when, so we've been able to eat outdoors, and now they're actually opening up indoors. So our numbers are coming down a little bit, but I actually went out to dinner last night in 16-degree temperature. All our restaurants opened up with outdoor spaces, but they put heaters in. So
Yes.
at least we're getting out a little bit, and you can go to a museum if you make reservations, and it's not as bad as other places. My son lives in LA, although he's coming tomorrow morning, and they've been completely shut down until this week.
Yes.
So it's just ridiculous, and it goes in cycles. So we're hoping that with people getting vaccinated, it will get better, but it's a huge task. Are you guys vaccinating?
I don't know. Many people here have concerns about the vaccine. In Egypt, we've got the Chinese one only up till now, and they haven't started. They're going to start by the doctors working in the isolation hospitals, and but even the normal people, some have big doubts about the vaccine. They're afraid to get vaccinated.
Yeah. I have to admit, initially I was a little nervous because they rushed it through, and then I just looked at the data and I said, well, if we don't all do it, we're all going to be wearing, masks and sitting home for forever. And so
that's right.
Yes, and I think that after a while, you won't be able, for example, to travel if you haven't taken the vaccine. You won't be able to do many things if you haven't taken the vaccine. So it's like, you should do it.
Yes. Oh, I've had both of mine. I had them. The second they opened it up to our group, I literally had the first appointment.
Oh, yes.
Yeah, and I'll tell you, we recently were about to do a seed loc on a patient whose husband
Good morning,
had
Dr. Rasha. Good morning, Dr. Maxime. This is Khalid Shiba. How are you doing?
Good morning, Dr. Khalid. Yes.
Very good morning. Happy to be you and see you right now. Kindly, we are live now on YouTube, so we need to keep our photos and videos as is without speaking, because we are live streaming YouTube.
Okay.
Till 2 o'clock, if you don't mind.
Okay, thank you.
Okay, I'm here.
Yes. Hello.
non-profitable and non-governmental organization. Good afternoon, my dear professors and colleagues. It's 29 January 2021, 2 p.m. Cairo local time. This is Dr. Sahar Mansour, the moderator of the Forced Life Expert webinar presented by Bahia Hospital. Bahia is a non-profitable and non-governmental organization that was initiated on 2015 to provide free service for Egyptian women that could not afford the expenses of screening and treatment of breast cancer. And since then, it had served a total of 145,000 Egyptian females as a center of excellence that provided all the facilities and investigations for early detection of breast cancer as laboratory, radiological, pathological, and integrated management of surgery, medical oncology, radiotherapy, and supportive treatment. The current webinar will discuss multimodality breast imaging and is sponsored by GE Healthcare in person of Maria Smith, Women's Health Marketing Manager. The event is a set of 3 sessions. First, Dr. Maxine Jacqueline, the United States of America, will talk about the correlation between COVID-19 pandemic and contrast-enhanced mammogram from 2 to 2:20 p.m., followed by a second session managed by the Egyptian professors Dr. Rasha Kamal, together with Dr. Iman Fakir and Dr. Shrihan Fakhri, whom will present multiple case reviews that will demonstrate the birth of the multimodality breast imaging at Bahia Hospital from 2:20 p.m. till 2:50 p.m. Then a third session with Professor Fiona Gilbert, United Kingdom, about her BIRAT trial in the screening of dense breast. Finally, there will be a panel discussion and question and answer session from 3:10 to 3:30 p.m. During the process of the talks, please feel free to write your inquiries in the Q&A window, and it will be discussed at the end of the session with the speakers. Now we'll start the first session with Professor Jocklison.
I have to start my video.
Yes.
You've stopped my video, so I can't.
So now you to start your video. Yes. Okay, allow me to introduce you, Professor Jocklison. Professor Jocklison, she is a diagnostic oncology radiologist with a special interest in breast imaging. She's currently the director of the radiology at the New Breast and Imaging Center at the Memorial Sloan Kettering Cancer Center, where she is an associate attending and associate professor of radiology at the Commonwealth Medical School. She will discuss the presentation entitled COVID-19 Pandemic and Contrast-Enhanced Spectral Mammography. You can proceed, Professor Jocklison.
Good morning, and I'd like to proudly say that I am no longer an associate professor. I am a full professor at both of those institutions. I've happily been promoted. Anyway, good morning, and so nice to be here with all of you, and I hope you're all doing very well. Now my host has disabled my participant screen sharing. I have a...
No, you share your screen.
It says host disabled participant screen sharing.
No.
When I click on it.
Okay, you can use it now.
Let's give it a try. Yes.
Okay.
Okay, so thank you for the kind introduction, and the topic that I will be addressing today is really what we can do with contrast mammo to help breast imaging during COVID-19. And let's see, why have my slides? Okay, so there have been a lot of studies done about the effect of COVID-19 on women getting their routine breast care. Because as you all know, when COVID-19 started, we stopped everything but most essential patient care in order to take care of COVID victims. So what we have learned is that nearly 1 in 3 women have delayed their mammograms. 29% of women say their breast health has become a lower priority. 45% of women say they're more nervous, are concerned about visiting a medical center in order to be taken care of for their routine breast work. 1 in 3 women say the pandemic has negatively affected their breast care. And 28% of women who had had mammograms since the start of the pandemic felt that they had moderate to severe levels of anxiety or fear. And I would imagine that's over and above what they have felt in the past. There's another way of looking at this, and this is the number of risk assessments women have undergone since the pandemic has started. And as you can see, that there has been a significant decrease in risk assessments for women. And this includes assessments by either breast imaging, breast surgery, and or genetics. And in fact, unhappily for those of us who are imagers, while all 3 assessments have declined, the largest decline was actually in breast imaging, and that was 62% of women. And in part, you can do some of the other assessments via telehealth, but for your imaging, you actually have to come in and have something done. So we have thought about different ways of making it more efficient to get your breast imaging, to do a better job, reduce the stress, and first of all, in the time of COVID, but also going forward. And I think contrast mammo is a really good option in the setting for both now during COVID and going forward. So contrast mammo has the advantage of, in one exam, giving you an anatomic evaluation of the breast, a regular mammogram, and at the same time, you're doing your vascular imaging. So rather than having a mammo plus an MRI, you have one examination. And so this could be the one-stop shop, and particularly in women who are at increase for breast cancer. Now, many times we do alternating screening, but certainly in times such as these, if you get your contrast mammo, you're basically getting your MRI and your mammogram. In the diagnostic setting, if you have symptoms, you can come in and rather than have a mammo and an ultrasound, which you do need, you can get the mammo ultrasound, but the mammo being a contrast mammo will also give you a likelihood of having breast cancer or not. And also, if you happen to have breast cancer, you've already performed the preoperative staging of that breast cancer. And in many situations at our institution and many institutions in the US, rather than taking patients to surgery during the beginning of COVID, when we didn't have hospital beds, a lot of women were started on neoadjuvant chemotherapy, which they could do rather than taking up OR beds and emergency room beds. And contrast mammo has also been demonstrated to be a good tool for evaluating women after neoadjuvant chemotherapy. So we have years of great data that demonstrate that contrast mammo is of great value in the diagnostic setting. And this is for women who have been called back from screening or women who have symptoms, and you can see in every single situation, the sensitivity of contrast is 93% to 100%. And the specificity is quite good as well. Not only that, we've demonstrated that if we find a cancer, that contrast is probably the best modality we have in accurately assessing the size of the index tumor. And so this is a great way to decide if somebody should have neoadjuvant chemotherapy first or allow for better surgical planning. And just several papers, one by Ava Fallenberg from 2014, where they looked at the ability of contrast mammo to stage the known cancer. And as you can see here, it's equivalent to MRI. So you can make the diagnosis with contrast mammo and at the same time preoperative staging. And again, great data in this multi-reader study demonstrating that looking at the area under the curve for using contrast compared to mammography, clearly contrast mammo is better and not significantly different from preoperative MRI. And just a few examples. This is a patient of ours who had a palpable breast mass, came in, had a diagnosis of cancer, and you can see the enhancing mass in the top image here and the non-mass enhancement on MRI. The solid mass, not surprisingly, was invasive cancer, and the non-mass DCIS, and this is the same patient. Contrast mammo shows you exactly the same thing, the breast cancer with the biopsy marker and the non-suspected non-mass enhancement on the regular mammogram. We have lots of good data on follow-up after neoadjuvant chemotherapy. The first study on this was by Dr. Iadi et al. And from Italy, and they did a prospective trial of 46 women where the studies were interpreted blinded to each other. So they compared MRI to contrast mammography. Both slightly underestimated residual tumor size, but contrast was better in predicting pathologic complete response compared to MRI. And when you look at the sensitivity and specificity, contrast was superior to MR. And this is just a nice example of a patient with a very large primary tumor, easily seen on contrast, MRI, and ultrasound. And you can see the marked enhancement. You can actually see a feeding vessel. The patient got neoadjuvant chemotherapy and was re-imaged. The enhancement completely went away. And this patient did have a pathologic complete response. There are data also from Arizona by Patel et al. Looking at the same situation and having the same results. Basically, contrast mammo is equivalently sensitive and specific to MRI in assessing women after neoadjuvant chemotherapy. So it's also, and talking about efficiency, is that whereas when my patients come in now, they have to have a mammogram and then they have a follow-up MRI, this does both in one appointment. And here's the example from Dr. Patel et al. And you can see an enhancing tumor in the upper breast. Post-treatment, you can see the biopsy marker, no enhancement, and again, complete pathologic response. We are about to have data coming out from our institution on 125 patients prospectively evaluated this way. And it's a great option in the US, it's much cheaper. And again, one-stop shop. And then there's screening. I mean, really, one of the biggest things is that women will be putting off their screening if they're afraid of coming in. And so while we have demonstrated contrast mammo to be successful in the diagnostic setting, it is a possible solution for assessing women at intermediate risk or women with dense breasts. And so we eventually started a prospective trial comparing contrast to MRI in a group of 307 women who had heavily pre-screened, have been heavily pre-screened with MRI for years. And so we didn't find that many cancers because they were heavily pre-screened, but there were 3, and there were 2 invasive lobulars, neither seen on mammo, both seen on contrast and MRI. And then contrast missed a quote unquote DCIS, which was a tiny focus. The patient didn't come back for a year, it was ADH and it was upgraded. But basically, it certainly showed promise for contrast mammo in this setting. And this is one of our patients who did have a negative mammo, and you can see just this little non-mass enhancement that was an invasive lobular cancer. This is a patient who was also being screened after our study, and interestingly with a false negative MRI. Woman with a history of LCIS had a very small area of non-mass enhancement. Unfortunately, my colleague didn't follow our protocol, which would have been to do an ultrasound, even though it was non-mass enhancement, but instead did an MRI, which was completely a reasonable idea, but the MRI was negative. The patient was getting alternating ultrasounds every 6 months between her mammos. So she came back 6 months later and there was a small cancer. And just in case you didn't believe it, there is the biopsy marker and the enhancing lesion. And in fact, this was a false negative MRI in a woman with invasive lobular carcinoma. People have now looked at comparing contrast mammo to ultrasound or mammo plus ultrasound. And this study from Israel was a 611 retrospective women comparing contrast to mammo alone. And these women were intermediate risk and had dense breasts. And you can see that the sensitivity of contrast, not surprisingly, was significantly higher. The specificity was lower, but the incremental cancer detection rate was 13.1 additional cancers by adding contrast. Of interest, many of these people did have ultrasounds, and ultrasound showed 73 additional lesions. None of the lesions that were found on ultrasound that didn't enhance were cancer. So that tells you that contrast can certainly be used to determine if you need to biopsy lesions that don't look too suspicious. This is a study by Klang et al. With compared contrast to ultrasound. And again, sensitivity was close, but contrast was better. But the difference in specificity is critical. So again, if you're trying to avoid additional visits, additional biopsies, contrast is extremely helpful. And so suspicious appearing contrast mammo associated with malignant biopsies, look at the p-value here compared to ultrasound. So these are ways we can reduce the amount of time our patients have to come in and also have unnecessary studies. And there are a lot of ongoing trials looking at this to get larger numbers. And here is the patient with false negative ultrasound, another LCIS patient. We have a huge LCIS population. These are those really hard breasts to look at. They're very dense, completely normal mammo. She had a focally enhancing mass in the upper outer quadrant, ultrasound by our technologists, and then one of my experienced colleagues could not find this on ultrasound. So she went to MRI, and it's a 1.5 centimeter enhancing invasive ductal carcinoma. So we looked at our data. We had 904 baseline contrast mammos for screening. It was a retrospective study. Most of our patients had increased risk for one reason or another, and 77% did have dense breasts. And our additional cancer detection rate was 16 per thousand. So we are looking at numbers similar to MRI. So in conclusion, COVID is one of the worst things to occur in our lifetime, and I think that's something everybody can agree with. It has made us re-examine our lives and our priorities in many ways. And unfortunately, for many women, that has put their breast health into a less important category and therefore puts them in a precarious position. And we all know if you delay your mammo by a month or two, it's not a big deal. But some women are delaying their mammos or delaying their chemotherapy or their hormone therapy. And we're beginning to see the effects of that. So we have to appreciate this and come up with ways that we can get our women taken care of in a more efficient, less stressful manner. And I think contrast mammo can help. Again, it is great in the diagnostic setting, so you can diagnose cancer and stage it at the same time. Once it's diagnosed, it is also possible to take care of the woman without an MRI. There are fewer false positives compared to MRI, which means fewer biopsies. Patients receiving NEO can actually have this as their preoperative staging and then just have a contrast mammo to follow up. And I do think it's a very promising tool for screening. So I thank you for your attention. I hope everybody stays safe and healthy, and let's look forward to the next time we do this in person.
Thank you very much, Professor Jefferson. It was very interesting and to the point talk. And now we'll go to the next session. We are going to review some interesting cases from Bahia Hospital Imaging Gallery through Professor Dr. Rasha Kamal. She's Professor of Radiology. She's the head of the Women's Imaging Unit, Kasrani Hospital, Cairo University, the president of the Egyptian Society of Breast Imaging, and was the first executive director of the presidential campaign for screening of the breast cancer in the Egyptian women, and chief consultant of breast imaging in Bahia Breast Cancer Center. Together with Dr. Iman Fakir and Dr. Shihan Fakhri, both are senior lecturer of female imaging, Cairo University, and consultants of breast imaging in Bahia Breast Cancer Center. Again, your questions are so much welcomed in the Q&A window, and it will be discussed with the speakers at the end of the sessions. You may proceed, Professor Rasha.
Yes, thank you, Sahar, for the introduction. As Dr. Sahar said, this session is divided in between me, Dr. Iman Fakir, and Dr. Shirihan. And I'll start the first part of the presentation, which is entitled a Step Out of the Comfort Zone of Fibroadenomas. When a breast lesion is seen on imaging and it completely fulfills the criteria of a fibroadenoma, breast imaging radiologists usually place themselves in the comfort zone. And it is my job today because changes always begins with one step outside this comfort zone. I'm going to take you this step out, and we will try to understand together what do fibroadenomas have to do with carcinomas. I divided this relationship into three scenarios, and I'm going to start with the first scenario, which is the inherent malignant potential of fibroadenomas. This is a 57-year-old female. She came for her regular screening mammogram. This was her screening mammogram in 2017, 2018. She missed 2019, and she came in 2020. And unfortunately, she developed a newly circumscribed mass lesion, which appeared isodense to the surrounding breast parenchyma. This was her contrast mammogram, and the lesion appeared circumscribed, faintly enhancing with dark septations, all features pointing to the diagnosis of a fibroadenoma. Actually, we had to go back to her previous ultrasound examinations. And yes, there was a fibroadenoma in 2017, and this was in 2018. But in 2020, this fibroadenoma increased in size and in vascularity. And this made us proceed to a further biopsy, and the pathology report came back with a fibroadenoma with foci of DCIS. This was the MRI examination of the same patient, and the lesion again showed features of fibroadenomas. It was circumscribed, faintly enhancing with dark internal septations. Unfortunately, looking on the left breast, there was an area with an increased parenchymal enhancement and a distorted parenchyma, and we were not sure whether this was an enhancing parenchyma or was it part of the background parenchymal enhancement, or whether there was an underlying breast lesion. And we had to go back to her previous mammograms. And again, comparing the previous mammograms going from 2017 to 2020, we had a subtle increase in the overall breast density of the left breast. And we went back to her contrast mammography, and actually we missed this focal numb mass enhancement, which was present in the left breast. A biopsy was taken and turned out to be an invasive lobular carcinoma. So in this case, we had it in her right breast, there was a fibroadenoma with foci of DCIS, and in the left breast, she had an invasive lobular carcinoma. And the teaching points in this case is that we should avoid the satisfaction of search. Whenever we have an evident lesion, we should look at the other parts of the breast in order to not to miss subtle breast lesions. We should always compare with previous studies, and any change in breast density, morphology, or an increase in size of any detected lesion, we should then proceed to biopsy. Case number 2 is a young individual. She's 29-year-old. She had a palpable mass in the right breast that showed recent increase in size. This is how the mass appeared on the ultrasound. It was oval, circumscribed mass lesion, which showed moderate vascularity with non-specific axillary lymph nodes. Our initial diagnosis was a fibroadenoma, and she was assigned a BI-RADS 3. But actually, we changed this diagnosis. When we looked carefully at the lesion, we discovered that there were microcalcifications scattered within the lesion. We recommended for a mammogram, and in spite that she had an extremely dense breast parenchyma, the lesion was evident with microcalcifications seen inside the lesion. A biopsy was taken, and the diagnosis came with a complex fibroadenoma with DCIS. And the teaching points in this case that microcalcifications are not accepted in fibroadenomas in young individuals, and that we should not deter the diagnosis of malignant breast lesions based on patient's age. This should be only done based on a biopsy. The third case is a 47-year-old female. She came for her annual follow-up screening, and she said she always had a fibroadenoma in the left breast. But when we looked at the mammograms and on the ultrasound examination, neither exams showed any criteria which fulfills a benign diagnosis. And she also had indeterminate axillary lymph nodes with focal cortical thickening. A biopsy was taken immediately, and the diagnosis came with a complex fibroadenoma with an invasive duct carcinoma. And maybe because of this invasive component that the fibroadenoma showed this irregular appearance. And the teaching point in this case that any lesion which does not fulfill benign criteria, even if long-standing in the breast, should be biopsied. Now we have to understand the actual relationship between a fibroadenoma and a fibroadenoma which develops a carcinoma. Fibroadenomas actually comprise both an epithelial and a stromal component. And based on this, they are classified into the simple fibroadenoma, and this is the adenoma that we see all the time during our routine work. We also have the juvenile and the giant fibroadenomas, which are large fibroadenomas, and they enter in the differential diagnosis of the phyllodes tumor. And the most important type of fibroadenomas is the complex adenoma, which has the real potential to change into malignancy. The epithelial component of a fibroadenoma may develop a DCIS or an invasive carcinoma with a reported incidence of 1 in 1,000. And this incidence is higher with complex fibroadenomas. Actually, the pathological features of complex fibroadenomas are reflected on how they appear on imaging. This is a case of a complex fibroadenoma. This is another case, and this is a third case. And if we look at the three cases, we will find that they have common features. Because complex adenomas have apocrine metaplasia, they have cystic spaces within, and because they have sclerosing adenosis, they appear irregular in outline. And because they are hypervascular, they increase in size and they show microcalcifications. And whenever we have a pathology report stating that this fibroadenoma is a complex fibroadenoma, this means that this fibroadenoma should be surgically removed. The natural history of fibroadenomas is either it stays stable and or it might decrease in size, and this happens in the menopausal, and we see the characteristic popcorn calcifications within. Or they might increase in size, and this increase in size might be physiological, but it also might be pathological, either due to malignant transformation or it was a misdiagnosis from the start. And the alarming signs when we see a fibroadenoma is the increase in size, the irregular outline, the cystic changes, the increased vascularity, and the calcifications in young individuals. Now we come to scenario 2B, which is the concomitant carcinoma with a fibroadenoma. And this time, it's not a carcinoma developing in the fibroadenoma, but the presence of a carcinoma elsewhere in the breast other than the fibroadenoma. Actually, there is debate in literature whether fibroadenomas increase the chance of developing breast cancer or no. And previously, it has been suggested that fibroadenomas might increase the likelihood of developing concomitant breast cancer. But actually, recent studies have proved that fibroadenomas themselves do not pose any risk of breast cancer development. But maybe the association between fibroadenomas and some carcinomas are likely related to the abundant estrogen and to an abnormal hormone receptor mechanism. Our first case is a 71-year-old female with a palpable mass in her right breast. Looking at the right breast, she had a mass lesion. On one side, this lesion was circumscribed with popcorn macrocalcifications, and on the other side, the lesion had a spiculated outline. And this is how it appeared on the contrast-enhanced mammography. Again, on one side, we had an involuted, non-enhancing adenoma, and on the other side, it was an invasive duct carcinoma, which has invaded the adjacent involuted fibroadenoma. This is another 43-year-old female with chronic eczema of the right nipple, proved to be Paget's disease. Her mammogram showed a heterogeneous dense breast parenchyma with faint, dense, subtle right paraareolar lesion. A targeted ultrasound examination was performed and showed two adjacent fibroadenomas with complex features. They even showed microcalcifications within. And when we have Paget's disease of the nipple, we should perform an MRI examination. And these were the enhancing adenomas with dark septations. And adjacent to these adenomas, there was subtle enhancing foci taking a segmental distribution in the breast. And there was also a differential enhancement of the right nipple areolar complex. Mastectomy was performed, and it revealed a complex adenoma with an adjacent high-grade DCIS. The teaching points in this case is that whenever you have Paget's disease of the nipple, please do an MRI examination, even if your mammography and ultrasound examinations are normal. And now we come to the last scenario, and this is the fibroadenoma mimics. And actually, we have a long list of malignant lesions which might mimic fibroadenoma. And unfortunately, these cancers may occasionally show benign morphology exactly mimicking benign masses in all imaging modalities. And some of them, unfortunately, also occur in young individuals. Our first case is a young individual. She's a 29-year-old female with mastalgia and a lumpy breast. She came for an ultrasound examination in November 2019, and she had multiple tiny adenomas within her breast, but one of these adenomas showed complex features. She was asked to come for a short-term follow-up examination after 6 months, and she came, unfortunately, because of the corona pandemic, she came in September 2020. Some of of the adenomas showed a stationary course, but the complex ones showed increase in size with the development of multiple adjacent similar ones. This was her MRI examinations, and she had multiple intensely enhancing irregular lesions with washout time signal intensity curves. A biopsy was taken and revealed a multifocal triple negative breast cancer of a grade 3. The teaching point in this case is that when adenomas have atypical features, the least things that we should do is a short-term follow-up, and any increase in size or change in morphology, we should proceed directly to biopsy, disregarding the age of the patient. The last case is a female with a palpable axillary mass lesion. This was her MRI study, and it showed she had a normal ultrasound and a mammogram. So she was referred for MRI. She had a tiny circumscribed mass lesion with rim enhancement, and this lesion actually showed a bright T2 and a stir signals. And we fell in the dilemma whether this is benign or malignant. We had to look for other features on the MRI, and actually she had associated diffuse skin thickening, and she had pathologically enlarged amalgamated axillary lymph nodes. A biopsy was taken and revealed a medullary carcinoma. And the teaching point in this case is that whenever you have indeterminate lesions, please look for other signs which might help you decide whether this lesion is benign or no. Look at the axillary lymph nodes and look at imaging findings in other imaging modalities. And by this, I come to the end of my lecture, and thank you all.
Now we'll proceed to Dr. Iman Faker. You may start your video. Iman Faker, we're going to show us some of other cases from the gallery of Bahia, interesting cases.
Good afternoon, all. Thank you, Dr. Sahar, for the introduction and for moderating this session. Thank you, Dr. Rasha, for this interesting lecture. In continuation to Dr. Rasha lecture, I will today talk about the phylloid tumor. If phylloids or not phylloids, that's the question. My first case is a 24-year-old female with a right palpable breast lump. Her ultrasound showed this well-defined hypoechoic lesion of heterogeneous echogenicity and mild intraregional vascularity. The patient performed a tissue biopsy, and it came to be benign phylloids. Another case is a 37-year-old female with a palpable right breast lump. Her mammogram showed this large, well-defined or lobulated lesion of intermediate density, which was confirmed by the ultrasound, which showed this large, well-circumscribed hypoechoic lesion with heterogeneous echogenicity. And a biopsy was taken, and it's proved to be a malignant phylloids. The following case is a 47-year-old female with a left palpable breast lump. Her ultrasound showed this large, lobulated, or rather well circumscribed with some borders of ill definition, complex solid cystic lesions, predominantly solid component, which shows mild or increased intralesional vascularity in color Doppler. And an MRI, this lesion showed to be also a complex multilocular lesion with parts of low and low T1 and bright T2, and other areas were intermediate bright in T1, and as we see here, this was intermediate bright in T1 and bright, more bright in T2 signal intensity. The stair showed that's a bright signal in the image, while the subtraction showed the lateral component to show the heterogeneous post-contrast enhancement. And a biopsy was taken. It proved to be a cystic malignant phylloids. The other case is a 51-year-old female with a right palpable breast lump. Sorry, it was not palpable. This case was not a palpable lump. The mammogram showed this small, rather well-defined lesion of intermediate density. Yet there was no abnormal suspicious mammogram findings. Yet in the ultrasound, it shows this lesion with the heterogeneous echogenicity, and some margins were just angular and with a coarse calcific foci within and tiny cystic spaces. In the color Doppler application, there were high RI reaching to 0.9, while in the elastogram was performed, it was high ratio, more than 4, which demonstrates likely a hard mass. A biopsy also was taken, and this proved to be a malignant phyllodes. Actually, this was a very small, we are not acquainted with this size of the phyllodes tumor. This is a 38-year-old female with a left palpable lump since 1.5 years. The mammogram showed this large or huge, lesion of increased density. Okay. The complementary mammogram showed this a huge complex solid cystic lesion as well with intralesional vascularity, and the biopsy performed, it was turned to be a borderline phyllodes. A 31-year female with a right palpable breast lump showed multiple or few large, well-circumscribed hypoechoic lesions with heterogeneous echogenicity. And the biopsy was taken from the largest one, and it was proved to be a borderline phyllodes. Actually, it was a case of multiple borderline phyllodes. The following case, a 39-year-old female with a status post-left lumpectomy for a benign phyllodes with a left palpable breast lump. This was the area of this scarring, and her annual follow-up showed this small lesion, hypoechoic lesion. Actually, it shows some ill definition in the in its margins, but unfortunately, it was set for a follow-up, close follow-up, 4-month follow-up, and it showed that increase in size and not that parallel orientation. We performed her, and sorry, there were tiny cystic spaces in within. And we performed a biopsy turned to be a benign phyllodes. It was a case of a recurrent benign phyllodes. My last case is a 52-year-old female with a status post-left modified radical mastectomy, and now she was coming with a newly developed large fungating mass. And her mammogram showed this huge mass of increased density replacing above the left breast, and also there was a ulcerative, it was ulcerating toward the skin. The complementary ultrasound showed this heterogeneous echogenicity. Actually, it was not wholly visualized by the surface probe due to its large size, and was confirmed by the CT, which showed the such mass, and also it proved to have a pathological axillary lymph nodes. A biopsy was taken also, and this time it was a malignant phyllodes. It's a recurrent malignant phyllodes. So in the following 4 to 5 minutes, I will give a short talk of teaching points about phyllodes tumor, which accounts for 0.3 to 1% of the mammary tumors and have similar histopathological appearance and clinical radiological features to fibroadenoma, which is the most frequent benign tumor of the breast. So phyllodes tumor in imaging can be diagnosed either benign or malignant. Benign, we set it as a PIRAT 3, sometimes 4A, and in malignant, we give PIRAS 4, either B or C. Here, the surgical biopsy is the cornerstone for the diagnosis of the phyllodes tumor, especially to know the type, either it's benign or malignant, and if it's a borderline. Because both are, or the 3 types are different prognosis and management, it's important to perform the biopsy. So the next question here is, it's important to distinguish between phyllodes and fibroadenoma. Actually, yes, it's very important to distinguish between them because they are different in treatment. Phyllodes undergo surgical resection, while fibroadenoma just follow-up or simple inoculation. And we should notice that 20 to 30% of the resected phyllodes tumor are malignant, and approximately 25% of the malignant phyllodes tumors metastasize. Phyllodes tumor can be a borderline, benign, or malignant, and we should be acquainted that the borderline or the malignant phyllodes metastasize. So for this, it's very important to distinguish between. This is a table showing the difference between the three types. Regarding the tumor margin, the benign phyllodes actually shows a well-circumscribed margin. The borderline shows zones of microscopic invasion, and the malignant is an infiltrative tumor, so it shows infiltration. The following question is how to distinguish between the fibroadenoma and the phyllodes. Some certain points may help us to differentiate between both. Phyllodes occur in older age group. It shows rapid growth, more common for recurrence, more than 3 centimeters in size, and its shape is irregular, while the fibroadenoma is more to be avoided. The fibroadenoma shows circumscribed margins, while the phyllodes shows microlobulated margins. Calcifications are more common with fibroadenoma, while they are less common or not common with the phyllodes. And the associated secondary findings are common in the malignant form of phyllodes, especially the skin changes or if there is surrounding interstitial edema. The fibroadenoma is a hypovascular lesion with a benign pattern of vascularity, which is a peripheral vascularity with central twigs, while the phyllodes showed high vascularity within the tumor. Regarding the imaging findings, the mammogram may show rounded densities with or without smooth borders, while in the ultrasound, the fibroadenoma shows a well-defined margin, and the phyllodes show more to be microlobulated or ill-defined. The fibroadenoma shows hypoechoic homogeneous internal echo pattern, while the phyllodes shows a complex internal echo pattern with internal cystic spaces within. In the MRI, the fibroadenoma shows the hypointense internal septations, which are consistent to the fibrous septae within the lesion, while the phyllodes showed internal cystic areas and clefts. So to summarize, we MD Anderson Cancer Center in 2012 postulated an initial workup for any case of phyllodes tumor, beginning with the patient presentation and the clinical suspicious for phyllodes to be a palpable mass and with rapid growth. While and the triple assessment history, examination, ultrasonography, and mammogram if the patient is more than 30 years, and again the core needle biopsy, which is the cornerstone in diagnosis. If the core needle biopsy turned to be a fibroadenoma, we will just observe or follow up. If it's indeterminate lesion, we'll do an excisional biopsy. If it's a phyllodes tumor, benign, borderline, or malignant, then we'll do a wide local excision more than 1 centimeter. And they postulated also a workup for the recurrent phyllodes. We add the chest imaging. If it's not metastatic disease, we do an re-excision, while if it's metastatic, it's considered as soft tissue sarcoma. And please always remember that what we see depends mainly on what we look for. And so we should be acquainted for every abnormal finding or abnormal variations. Thank you very much.
Thank you very much, Dr. Iman Fakri. And now we're going to proceed to Dr. Shiryan Fakri with more interesting cases from the Bahia Gallery, Breast Cancer Foundation and Treatment. Dr. Shiryan, may you share your screen, please? Fakri, you may stop sharing your screen.
Yes, I do.
Okay, Shiryan.
Okay. Thank you, Dr. Sahar, for this nice introduction. And my session today is about lobular carcinoma, taking a step to change the invisible into visible. My first case is about a 65-year female patient with left nipple crustation.
Your screen is not shared.
Okay. Is it shared now?
No, you still.
Maybe Iman has to stop sharing first. Or
Iman is actually stopped sharing. Sharihan, you can try it now.
Okay. I'm sharing the screen. Okay.
Sharihan, you need to step on the share screen button and you share your presentation.
I'm doing so.
Yes, okay.
Okay.
Okay. Okay, you can proceed, Sharihan.
Okay. My session is about lobular carcinoma, taking a step to change the invisible into visible. My first case is about a 65-year female patient with left nipple crustation. Her mammography revealed no gross abnormality, no gross masses, and it was reported as normal. By ultrasound, there were dilated ducts with internal contents, yet no vascularity. Yet considering the patient's age and the clinical condition and the equivocal ultrasound findings, contrast-enhanced mammography was requested. It was reported as bilateral background nodular enhancement with no suspicious enhancing lesion, and accordingly, follow-up after 6 months was recommended. After 6 months, ultrasound was done and revealed this left breast subtle parenchymal alteration. The lesion was not palpable and biopsy was not feasible, so MRI was requested. On MRI, we can see these left breast multiple enhancing nodules with intervening linear non-mass enhancement, and it was proved as an invasive lobular carcinoma. So on reviewing the previous mammography, we can see these subtle areas of architectural distortion. And on reviewing the contrast-enhanced study, we can see these multiple faintly enhancing speculated lesions. And unfortunately, it was missed. The second case is a 58-year female patient with mastalgia. Her mammography revealed no gross masses, and it was reported as normal. On ultrasound, there was no breast masses, but there was a suspicious left axillary lymph node with focal cortical thickening. So fine needle aspiration cytology was done, and it revealed metastatic lymph node. Accordingly, contrast-enhanced study was recommended, and we can see these left lower breast non-mass linear enhancement. And on reviewing the mammography, we can see this subtle parenchymal distortion. So second look ultrasound was recommended, and we can see this small hypoechoic lesion, which was proved to be invasive lobular carcinoma. The third case is about a 51-year female patient with coming for screening, and her mammography revealed this one view asymmetry, which was not that appreciated in the CC view. And by ultrasound, we can see this large echogenic altered parenchyma with posterior acoustic shadowing. Biopsy was done, and it revealed invasive lobular carcinoma. So contrast study was recommended, and we can see this upper outer quadrant faint non-mass enhancement, but still there were some indeterminate enhancing lesion. So MRI was requested, and we can see only this right-sided speculated lesion with more deep extension. And on comparing the MRI with the contrast-enhanced mammography, we can see how MRI was better in defining this lesion and delineating its extent. Our next case is a 73-year female patient with left axillary mass. Mammography revealed left breast diffuse skin thickening, and global asymmetry may be related to edematous changes. On the ultrasound, there was no breast masses. There was just the amalgamated left axillary pathological lymph nodes. MRI was recommended, and we can clearly see this retroareolar hypointense mass with rim enhancement, and it was proved to be invasive lobular carcinoma pleomorphic variant. So these cases show how challenging is the diagnosis of invasive lobular carcinoma. And this may be due to its tendency to grow in a diffuse pattern with a less desmoplastic reaction. And that's why it's most likely to present with a non-palpable abnormality and may not be detected in the standard imaging technique, maybe especially if of low density or if presenting with subtle abnormality. It is a common cause of missed breast carcinoma with high false negative rate. And there are different histological variants of invasive lobular carcinoma. In all, there is lack of cell cohesion, and the most aggressive of them is the pleomorphic variant. So it's important to know that invasive lobular carcinoma can appear as a one-view asymmetry, and that the density of the abnormality may be equal to or less than that of the fibroglandular tissue. Our next case is a 35-year female patient with left axillary tail mass. On mammography, we can see this large hyperdense mass with a partially circumscribed margin and a partially spiculated and irregular margin. In ultrasound, we can see this large irregular hypoechoic mass, which was pathologically proved to be invasive lobular carcinoma pleomorphic variant. And accordingly, MRI was requested, and we can see this hypointense large lesion with rim nodular enhancement, yet displaying the type 1 progressive rising curve, which is not expected with breast cancer. But however, some studies stated that invasive lobular carcinoma may not demonstrate the classic pattern of rapid enhancement and wash out as the other invasive breast cancer. Our next case is a 55-year female patient presenting with left breast lump. Mammography revealed this large speculated mass lesion, and there is an indeterminate asymmetry on the right side. We can see the underlying microcalcification on the left side. And on ultrasound, we can see this speculated hypoechoic lesion, which was proved to be invasive lobular carcinoma. Contrast-enhanced study was recommended, and we can see these multiple enhancing nodules away from the dominant mass. There was no right breast enhancing lesion, and accordingly, that was a case of a multifocal invasive lobular carcinoma. Though not expected, but invasive lobular carcinoma mostly appears as a speculated lesion. And though microcalcification is not that common, yet its presence does not rule out invasive lobular carcinoma. Our next case is a 39-year female patient with left breast firm lump. On mammography, there is left breast diffuse skin thickening, and there is a global asymmetry. On ultrasound, we can see this large infiltrative left breast mass lesion. There was no masses on the right breast. It was proved to be invasive lobular carcinoma. So contrast-enhanced study was recommended, and on MRI, we can see this extensive area of non-mass enhancement infiltrating the nipple areola complex. Yet, on the right side, there were these multiple enhancing lesions with intervening linear non-mass enhancement. Some of they display the delayed washout curve, and this is the MIP images, and this was a case of a bilateral invasive lobular carcinoma. So please, in your step-by-step evaluation of lobular carcinoma, the contrast-enhanced study is mandatory in order to allow better delineation of the extent and detection of multiplicity and bilaterality. Our next case is a 37-year female patient with the history of previous right-sided lumpectomy. The challenge here is this dense breast. However, we can see right-sided nipple retraction with suspected retroareolar architectural distortion. Also, we can see this well-circumscribed lesion of medium density. On ultrasound, there were multiple suspicious and probably benign lesions, and in this case, contrast-enhanced study is mandatory. On contrast-enhanced mammography, we can see this intensely enhancing speculated retroareolar mass on the right side, but also we can see these bilateral multiple enhancing lesions. So now the question is, if this poses multifocal or multicentric, and should I consider all these enhancing lesions as suspicious? So it's first we have to take a close view on these groups of lesions, and we can clearly appreciate that the ill-defined speculated margin on the right-sided lesion, unlike the well-circumscribed margins of other lesions. So this case was a right multicentric invasive lobular carcinoma with bilateral, probably benign lesions. Please, in malignant process, you should enhancing lesions should are not necessarily suspicious, and the interpretation of contrast-enhanced mammography should follow the MRI by res lexicon. In these scenarios, second look ultrasound will be a very valuable tool. Our last case is about a 68-year female patient with left breast lump. On mammography, we can see these large speculated hyperdense lesions on the left side with a pathologically infiltrated lymph node. On the right side, this segmental pleomorphic microcalcification. On ultrasound, there was a large infiltrative left breast mass with the pathological ipsilateral axillary supraclavicular and infraclavicular lymph nodes. There was no masses on the right side, and biopsy was taken from both sides. And the diagnosis was left-sided invasive lobular carcinoma and right-sided DCIS with no invasive component. Metastatic workup was done, and there was diffuse peritoneal thickening and nodularity, denoting peritoneal deposits, and also there were widely scattered osseous deposits. Actually, there are some differentiating points between invasive ductal carcinoma and invasive lobular carcinoma, with lobular carcinoma being the second most common and more likely to be unpalpable. DCIS is a precursor of breast cancer and should be excised. Yet, lobular carcinoma in situ is not a precursor, but it is associated with increased risk of breast cancer, apart from the pleomorphic variant, which should be excised. Speculated masses are the commonest abnormality in both of them. Calcification is most common with the invasive ductal carcinoma. The one view abnormality and the multiplicity and bilaterality is more with the invasive lobular carcinoma. Metastasizing invasive ductal carcinoma may present most commonly with pulmonary or osseous deposits, unlike the lobular carcinoma, which may present with visceral metastasis. So now, how to turn the invisible into visible like this hidden animal in the jungle? First, you have to accept that invasive lobular carcinoma can be missed, and it's not necessarily your fault. Then use your available tools whenever possible, like compression view, ultrasound, and tomosynthesis. And if still indeterminate, use contrast-enhanced study and preferably MRI. And in pathologically proven cases, recommend contrast-enhanced study for better delineation of its extent, detection of multiple and bilateral lesion. Thank you, and thank you, Bahia Radiology team. I am honored to be one of you. Thank you so much.
Thank you very much, Dr. Shrihan, Dr. Iman Fakir, and Dr. Asha Kamal. The cases were very interesting and with very variables with many findings. And now we're going to proceed to our next speaker, which Professor Dr. Fiona Gilbert. Actually, Professor Dr. Gilbert is a Professor of Radiology and Head of the Department of Radiology, University of Cambridge, Honorary Consultant Radiology at Edinburgh Hospital, Cambridge University Hospital NHS Foundation Trust. She's the Chair of the Academic Committee of the Royal College of Radiologists and Chair of the NCRI Imaging Advisory Group. The title of her talk will be the Personalized Screening Dense Breast by Rats Trial. Professor Gilbert, you may proceed.
Thank you. Thank you so much for that kind introduction, Dr. Mansour. It's a real pleasure to be speaking at this webinar today, and congratulations to the Bahia Foundation for putting on such a good program. Let me just share my screen.
Yes, please.
Now, can you see my slides?
Yes. Yes, proceed, Professor Gilbert.
Excellent. Thank you very much. And you can hear me okay, can you?
Yes, very well.
Thank you. That's great. So my talk today is about personalized screening. And hold on. So what we're discussing is basically risk adaptation and what we can do differently as radiologists. We need to be, at the moment, we offer all women the same mammography examination. And we think that we could actually do this much more effectively and in fact, more cost effectively. So what we would like to do is accurately assign breast cancer risk to the women who are coming to screening. And we would ideally like to identify those women who need a supplemental imaging or an alternative imaging test, such as tomosynthesis, contrast we've already heard about, whole breast ultrasound, or MRI. So we know that there's lots of risk factors for breast cancer. We know it's an age-related disease. We know that breast density confers increased risk. People have a family history are at increased risk. People with an increased body mass index. And of course, there's the specific genetic factors. And you can see the images along the bottom show fatty breasts increasing to very dense breast tissue. And of course, increasing risk with increased amounts of breast tissue present. So there's been a number of studies published on breast cancer mammographic density and breast cancer risk. And this, I particularly like these publications, which were systematic reviews and meta-analysis, including over 14,000 cancers, 226 normal cases from 42 studies. And they showed that percentage density was actually a much stronger indication of breast cancer risk than either the Wolf classification or the subjective BI-RADS classification. And the relative risk compared to fatty breast, you can see in the bottom here. So you can see that if in the lowest quartile of density, it's a 1.79 risk, whereas if you look at the highest quintile of density here, it is above 75%, there's more than a 4-fold risk of developing breast cancer compared to the fattiest categories of density. And here you can see, younger women here, increasing breast density, older women still, increased density is a big risk factor. So no matter which way you cut the data, density is always an important risk factor. So as I said, you've got the visual assessment, BI-RADS, Boyd, a visual assessment scale, which is a 1 to 100 scale, using a 10 centimetre line, and you mark what you think the density is. Those are all reasonably good measures, but are difficult to reproduce. And then you've got semi-automatic thresholding with percentage density area, such as cumulus. You've got automatic area-based densities, and these are much more consistent, repeatable, and reproducible, but don't tend to correlate with each other. And there's a number of different systems that are available out there: Libra, Med Density, Paralook, Densitas, Stratus, and Volpara. And then, of course, you've got volumetric methods as well, such as both Quanta and Volpara. So a number of different tools that are available to us. But we're not actually using them yet. And as I said, it's because the subjective tools, there's big overlap between the different densities. In one study, showed that about up to 18% of women were reclassified from a dense category to a non-dense category. So that's, of course, quite confusing for women if they're getting different people telling them different breast densities. As I said, these commercially available tools are repeatable when you use them repeatedly, but they don't tend to correlate terribly well with each other. And so when different countries did a systematic review of these density tools, UK, Australia, and US have all published, they did not think the density tools were yet ready for clinical decision making. But we're coming under increasing pressure from women, particularly as we are now showing that supplemental imaging is beginning to be effective. So what about risk assessment? Usually a number of first and second degree relatives who've got breast or ovarian cancer are counted. You want to know the age of their diagnosis. If they were very young, obviously that's an increased risk for that individual relative. What was the age of the patient's menarche, their menopause? Did they use HRT? In our country, in the UK, the GPs can do some form of risk assessment, and then they'll refer them to a specialist genetics clinic. And we use a variety of risk assessment tools: Tyrer-Cuzick, Wadicea, the Breast Cancer Surveillance Consortia, or Hughes models. And these are available all online, and some of them now incorporate mammographic breast density. But what do we know about the different risk factors? Well, we know that if we take these curves here, this is a normal population distribution, and what we can do is we can add in different risk factors you know, adding in the relative risk. And so you can shift this bell curve to the right. And we know that we can identify about 4% of women who are at very high risk, and they're going to get about 18% of the breast cancers. By shifting, by using these known risk factors and shifting this curve to the right, we know that we can then identify about 20% of the population who are at very low risk. And they get less than 4% of the breast cancers that we're normally picking up. And so this is important information, because perhaps we should be doing less for these women, and we should definitely be doing more for these women. And we know that in this higher risk group, the BRCA carriers are there. And it's about, the BRCA carriers account for about 0.4% of these women at high risk, so about 10% of these identifiable women, and they get about 3.5% of those cancers. Okay, so what can we use? The variety of online tools that we've got. As I said, Boadicea, Tyrer-Cuzick, Gale, and the BCSC. So here, I don't know if you can read this table, looking at the polygenic risk scores, mammographic density, and say the Tyrer-Cuzick model or the Gale model. You can look at how that changes the area under the curve. And the area under the curve is basically, it's a measure of the accuracy of the tool that you're using. So you can see that by taking a polygenic risk score, that's the single nucleotide polymorphism, and adding them all together, is 0.64. You add in mammographic density, and there's a very small incremental difference. If you take Tyrer-Cuzick alone, it's 0.58. If you add in mammographic density to Tyrer-Cuzick, again, there's not much of a difference there. Similarly, with the Gale, a slightly lower accuracy, and if you add in mammographic density, it improves it slightly. So none of these are really ready to be used in earnest for population screening and to sort out women into higher risk and lower risk. And so there's a lot of research going on. There's the MyPEBS European study, which is looking at women's risk factors based on SNPs and breast density, and then altering the frequency of their mammography. There's the Parallel Wisdom study, which actually started earlier in the west coast of America. There's the PROCAST Manchester study. So lots of very interesting research going on to try and identify how we should be applying these risk models and mammographic density in terms of what we should be offering to our women. So I thought very interesting paper from the Swedish group. This is from the Karolinska. They based this on the KARMA database, and they took 10,000 women with 947 breast cancers. And what they were able to do was predict, using the mammogram plus lifestyle, certain features from the mammogram, plus the lifestyle information, they were able to predict who was going to develop a cancer in 2 years' time. And so I thought this was a particularly interesting piece of work. There was an 8-fold difference between the women who are at the highest risk compared with those who are at the lowest risk. And if you were in that very highest risk of category, then the women were much more likely to get larger cancers. And of course, this is because breast density is playing such an important factor here. It's really hiding those larger cancers. And so women have to wait until the next round of screening 2 years later before their larger breast cancer has then been found in amongst that dense breast tissue. So just, I thought, an illustration of how that risk is being applied. Another very important study from Holland, single center study, large number of well, a huge big screening population here, when they looked at cases between 2005, 2009. And what they were able to look at was they used Volpara density grades mapped onto BI-RADS. They looked at the different examinations. So 20% were very fatty, 7.7% fell into the very, very dense breast category. And they said that, yeah, okay, breast cancer detection is about this, is low in fatty breasts and increases for BI-RADS B, C, and D. But the shocking thing here really is, I think, is the number of interval cancers that are occurring in the BI-RADS D category, where mammographic sensitivity dropped to under 60%. But even in the C category, you can see there's quite large numbers of interval cancers. And so this is why we're concerned about breast density and what we should be offering women with this very breast density. So interval cancers are a problem because they're often larger and higher grade and they have a poor prognosis. So what have we got? Well, obviously we're using mammography all the time. We're shifting now to tomosynthesis, but we should be also considering whole breast ultrasound, contrast enhanced mammography, as Professor Maxine Jockelson, congratulations, gave an excellent presentation on, and of course abbreviated MRI. Tomosynthesis you're very familiar with. It basically decreases the overlapping shadows, so it decreases your recall rates and it increases the conspicuity of very small lesions. It's going to reduce your false negative rate. It's rarely an imaging test that does both things. Not only does it improve sensitivity, but it improves specificity as well. It's unusual for that to happen. So a number of studies have shown that DBT is very useful. A word of caution though, DBT we found is not helpful in BI-RADS D women. The density is too great for that multi-view examination to actually make much of a difference. So it's certainly very good in BI-RADS C women, but I think not that helpful in BI-RADS D breasts. What about whole breast ultrasound? So whole breast ultrasound, I think, is a really good technique because it's an automated acquisition using ultrasound. We can train our sonographers to do it and they will produce really good quality examination. It takes about 20 minutes and the reading time's about between 5 and 10 minutes. The disadvantages is that it's not as sensitive as MRI. There's large numbers of images to look at. But the advantages is no ionizing radiation. And certainly in most of the studies, there was an additional 4 cancers per 1,000 cancers picked up. So that's very interesting results and means that we should be certainly looking at this technique. And the women, of course, they don't mind it. And the great thing is that the CAD tools, the computer-aided detection tools, are being developed to help us read these ABIS examinations more rapidly. So a number of ultrasound studies, mostly showing an additional 4 per 1,000 cancers compared to a normal mammographic examination in virtually all these studies. Similarly, in the Kelly and Somosite study, and also in that Swedish study, I think it was a 2.4 additional cancers found with ABIS. The concern with ultrasound is the high recall rates. And certainly in the initial Akron first round, it was 21%, but it dropped to 11% in the subsequent rounds. The JSTART study was a 12% recall rate compared to a 9% mammographic recall rate. Somo Insight was initially a very high recall rate, but the Swedish study, where they already have low recall rates for their mammograms, only had a slightly increased recall rate with the addition of whole breast ultrasound. So it's something that we certainly need to be aware of and work on. Contrast enhanced mammography, we have had that superb talk from Maxine, so I'm not going to go through that, but certainly a very useful technique, much better than mammography in the dense breast situation. And the specificity is pretty good as well, and comparable, we think, to MRI. Overall, the sensitivity for contrast enhanced mammography was slightly less than MRI in a number of the studies, but the positive predictive value was actually better. And another study from Maxine's group. So what about MRI? MRI, I think, is something we should be taking very seriously when we're dealing with women who have got BI-RADS D, extremely dense breast tissue. So I think this is a landmark study published in the New England Journal of Medicine from the Dutch group. They randomized 32,000 women who had very dense breast tissue between the years 2011 to 2015, and over 8,000 were offered a 3T MRI examination. Now, their primary outcome measure in this study was what was the interval cancer rate at 2 years. Because, of course, one of the problems that we're always given, you know, if you're doing screening examinations, one of the challenges that we've got when we introduce a new technique, are we just increasing the number of cancers that are being overdiagnosed? Are we just finding more cancers that women would never have known about in their lifetime had we not done this new technique? And of course, that's harming a patient. That's not actually giving them any benefit whatsoever. So the interval cancer rate is a really good outcome measure when you're introducing a new technique. Can we reduce the number of interval cancers? So in this study, in this MRI study, the cancer detection rate shot up to 16.5 per thousand. There was a high recall rate. It's a high recall rate for Holland, 9.5%. It was almost 4 times the background recall rate for mammograms. But the interval cancer rate was halved. So this was highly significant result. So normally in Holland, they would get 5 cancers per thousand in their 2-yearly screening with the mammograms with these dense breasts. I want to point out these are the very dense breasts. Overall, it's not as high as that. But the interval cancer rate was halved, dropped to 2.5 per thousand in the MRI arm. So this is a very important study. So what kind of cancers was this study picking up? And the reality is that the MRI was able to pick up some of the grade 3 cancers, but actually pick up mainly grade 1 cancers, but also a large proportion of grade 2 cancers. So this is relatively reassuring that we're not just picking up additional small breast cancers. Some of these ones that were being picked up, of course, are cancers that would be found in the next screening round. So the advantages of MRI, well, the problem with MRI is it's costly and it's a long examination. So actually what we want to be doing is an abbreviated MRI examination. And I think you've probably heard a lot about abbreviated MRI from different speakers in the past, advocated by Christiana Kuhl, now a long time ago. But the reality is that the diagnostic accuracy of a 10-minute MR examination compared to a conventional 30-minute MR examination is almost as good. The MRI sensitivity certainly matches contrast enhanced mammography and is much better than tomosynthesis and FFDM with ultrasound. It's actually the shorter examination is more acceptable to women, and of course it's cheaper because it's not using so much machine time. And also the reading time is quicker for the radiologists. We did a meta-analysis of all the published abbreviated MRI studies, and we found that in fact the reading time was shorter for abbreviated MRI, 7 minutes compared to almost 20 minutes for a full protocol examination. And the examination time was 7 minutes compared to a 20-minute full protocol examination. And the reading time was half that of a full protocol examination. So certainly we're saving money here, saving radiology and machine time when we do the abbreviated examination. What about the sensitivity? Well, certainly it virtually matched. The abbreviated MR examination virtually matched a full protocol examination. You can hear sensitivities here, 90% for abbreviated MRI, 92% for full protocol, and specificity almost as good with the full protocol examination. So this looks, I think, very encouraging. The big ECOG study run by Chris Comstock and published in JAMA this year showed that the abbreviated MRI was much better, 96% sensitivity compared to tomosynthesis of 40% in these women with BI-RADS C and D. So very important study here. What about the BRAVE trial? In the UK, we're taking women who've got high C or BI-RADS D density, who've got a normal mammogram. We're going to recruit 12,000 women from these 6 sites across the UK, and we want to look at different imaging modalities. We're comparing whole breast ultrasound with contrast enhanced mammography, with abbreviated MRI, with standard mammography. We're going to put 3,000 women into each arm, we're randomizing them, and then we're going to repeat the examination within an 18-month period and then have their routine screening again. So we think this is a really, really important study, and we want to look at the size and the biological type of cancer that each of the different modalities is detecting. So we think an important study comparing the different imaging modalities in this one trial. So what do I think? I think that women need to be treated as individuals because certainly not everyone's at the same risk. I think we need to identify which of our imaging modalities will find the more biologically important cancers. And absolutely, we have to reduce our interval cancers. And I think we need to be thinking about redistributing our resources and certainly reducing imaging for those people who are at very low risk. Thank you very much.
Thank you very much, Professor Goldberg, for your very interesting talk. And now it's time for the discussion. We are going to start with the Q&A questions session. And first, my question for Professor Dr. Rasha Kamal.
Yes.
Okay. There are a lot of questions about the adenomas, and the first question is asking about if we are going to do biopsy for fibroadenoma with cystic areas.
Yes, I stress the features of the complex fibroadenoma, not for all fibro, because I got questions on the WhatsApp. They told me, are we going to biopsy all fibroadenomas or no? What deserves really biopsy is the complex fibroadenoma, and it has specific features, as I stressed in my lecture. It's usually the patient comes complaining of an increasing in size, increase in the size of the fibroadenoma, and when we view the fibroadenoma on an ultrasound examination, we see cystic spaces, and we see microcalcifications within the fibroadenoma, and they usually have an irregular outline. I have seen another question telling me how can we differentiate the complex fibroadenoma from the phylloides tumor. Yes, actually, the cystic spaces in the complex fibroadenoma are different pathologically from the cystic spaces in the phylloides tumor. In the phylloides tumor, they are vascular channels or vascular spaces. When we apply the Doppler, they show vascularity, but this is not the same in the complex fibroadenoma. The microcalcifications are commoner with the complex fibroadenoma, and they are not common. It is not common to see microcalcifications in phylloides tumors. I have only seen it once, and when this lesion was operated upon, there was foci of DCIS inside the phylloides tumor. So it's not common to see microcalcifications within phylloides tumor. Phylloides tumors are usually rapidly growing, and we should respect the complaint of the patient. And this is the a main issue in diagnosis or in suspecting phylloides tumor, is that the patients usually come with a rapidly increasing size mass, and the condition is not like this in the complex. It increases in size, but not as rapidly as the phylloides tumor. And maybe the complaint of the patient is very important, because even on a pathology basis, sometimes if we take a true cut biopsy, we find a lot of reports coming back with a cellular fibroadenoma, and in this case, they suspect the presence of a phylloides tumor, but they are never sure that this is actually a phylloides tumor. Yes.
Well, another question is about the size of the adenoma. When to say that the adenoma has increased in size? What is the
actually, according to the BI-RADS lexicon, that any lesion which shows an increase in size of more than 25% in 6 months duration should be considered a considerable increase in size.
Okay, thank you very much, Professor Rasha Kamal. Professor Joclison, I would like to ask about the contrast-enhanced mammogram and your experience. You have experienced a lot of contrast-enhanced mammogram, and now there is the era of the abbreviated MRI. It could be of a comparable timing. Do you think contrast-enhanced mammogram have a privilege over MRI, especially in the COVID-19 pandemic, and we need to schedule the patient a very limited time and not to make the patient recall a lot of sessions for examination?
So I think that Fiona study is going to be really interesting, comparing them. My guess is that since abbreviated MRI is probably equivalent to full MRI in terms of sensitivity, and there's one paper on mutation carriers that says it's more specific, I think it's a great contrast tool. The nice thing about contrast mammo is it does also give you the anatomic evaluation on the mammogram. And so it is more of a one-stop shop. the specificity comparison will be interesting because at the moment, full MRI is less specific than contrast mammo, but abbreviated may be more specific because there are fewer sequences for you to find stuff you don't need to find. So I think a head-to-head study will be great, but the beauty of contrast mammo, it is a one-stop shop for the patient.
Okay, another question is about that sometimes we get the very busy breast with a lot of enhancing nodules within it. How we could differentiate between that the enhancement suspicious or not, on what basis, especially that the contrast enhanced mammogram doesn't have a curve or a kinetic analysis like the MRI.
That's true. And you know, there have been multiple studies, and we're actually about to start a whole study on BPE and looking at more specific questions. Right now, there are some data that suggest that BPE, although in our study was equivalent to MRI, is that you generally don't see as much BPE in contrast mammo than you do on MR. But there are patients that I have no doubt that we would be missing a small lesion because we don't have the kinetic curve for sure. And I think it happens less frequently because, as I say, I don't see too many people with marked background parenchymal enhancement on contrast mammo the same way I may on MR, but it is a potential source of false negatives.
Do you mean that the contrast enhanced mammogram may have the privilege over MRI, that there is no the background contrast uptake that's frequently seen on MRI?
Yes.
I'm so sorry, I didn't get the question. Ask me again, please.
Do you mean that one of the privilege of the contrast enhanced mammogram that there is no background contrast uptake to make the camouflage as in the MRI, and so this is make it specific by itself?
Right. Well, I think the beauty of MRI, especially if you're doing rapid early sequences, you can actually look for enhancing lesions before the BPE comes in. So we use DISCO. There are lots of sequences where you can actually beat the BPE. With contrast mammo, it's a one-shot deal. It's about 2.5 minutes. So different patients will have BPE showing up for your images, and it is a potential source of a missed lesion. However, I think if you look at all the data so far, looking at sensitivity between the two examinations, it's pretty close. You know, a lot of studies show that it's equivalent, MRI versus contrast mammo. And if there is a slight decrease in sensitivity, it's quite small. So the BP issue must not be a huge issue for all the patients, all the studies that have been performed. I think there's no question. Some places actually time their studies around women's menstrual cycles. We don't. We have a paper demonstrating that it's not of any value with MRI, and nobody's really looked at that for contrast mammo to see if the time of the cycle that you do the contrast mammo will make a difference. We do know that more BPE is more likely in premenopausal women, all those kinds of things, but it hasn't seemed to be something that we need to pay attention to. So yes, I think we have occasionally missed a tiny cancer because of a lot of BPE. I think that I've seen cases, but I think if you look at the large numbers of comparative studies still show equivalent sensitivity.
Thank you very much, Professor Jacqueline. I'm going to Professor Galbert. Professor Galbert, are you with me?
Yes.
Okay, I'm going to ask about the abbreviated MRI. Do you recommend this abbreviated MRI? It's going to have the same, have your lecture goes with the same specificity and same sensitivity as the actual protocol with the MRI?
I'm sorry, I didn't catch that.
The classic protocol of MRI, do you find the abbreviated MRI having the same sensitivity and specificity, or it enhances some parameters?
So I think we're enjoying using the abbreviated MRI. You've got to be careful. We're kind of very conscious about our recall rates, and still at the moment, our recall rates are quite high with the abbreviated MRI. So we're kind of working on how to reduce that. It's difficult because when you're doing annual examinations, you can kind of kind of ignore a 5mm lesion if you're not too worried about it, but it's more difficult if you're doing them less frequently. So we're at the moment, I think we're still on our learning curve with abbreviated MRI. I think you just have to get used to it.
I have a question, please, but Sahar, could you give me the permission to share my video, please?
Okay.
But you use the abbreviated MRI in the screening context only, not as a diagnostic tool.
So we're using abbreviated MRI in the screening context. So we're doing it. The BRAVE is a screening study. So we're taking women with normal mammograms who've got high breast density and randomizing them to either abbreviated MRI, contrast mammography, ultrasound.
Ultrasound, yes.
A control group. So we're getting one of those examinations.
But we cannot call it equivalent to a full protocol MRI in the diagnostic setting, I think. If you have lesions, you want to identify multicentricity, multiplicity, bilaterality. Would you go for
some of the studies when they were using the enriched cohorts were doing exactly that. So they were doing like a retrospective evaluation, and there were women who'd been recruited from either screening, high risk, or symptomatic clinics, and they took just the first post-contrast examination, and they created a MIP, and then readers, and they did a retrospective reader study, and so they found remarkably good results.
With the abbreviated, yes.
So that was with symptomatic patients who were being used for those studies.
Yes.
Okay. And we're going to start looking at some of our post-neo patients, just because you can just take a couple sequences out of the whole. I mean, it's the easiest thing to do. You have the whole study and you pick a couple sequences and take a look. So we're also, I think it's very important to look at that, because it could be that it'll be just as good as well.
Exactly.
But don't you think that in the post-neoadjuvant, the patients usually have delayed enhancement for? So if you take the first few minutes, that will give you a false impression that there's, for example, a complete response, and then the pathology will come with the residual disease.
But the beauty of it is, if you're going to do it retrospectively, you can pick the early sequences and then you can pick the late sequences.
Yes. Yes.
I mean, I think you're absolutely right. But I think that will be part of the interesting thing, to do big studies and using early and late sequences, because certainly I agree. I've seen cancers that I don't see at all until the much later sequences.
Yes.
Same with us. Particularly, when there's been a cancer there and they've had chemotherapy, then often the enhancement is so dampened down that you need to look really carefully and really window it carefully.
Right. So it may not be abbreviated. It actually may not work as an abbreviated exam if you're waiting.
You're just testing whether it will or not. Yes.
Right.
Yes. Sahar, any more questions?
You may share your screen if you want to show one of your cases. Dr. Rasha, you asked to share your screen if you want to.
No, I didn't ask to share my screen. I asked only to share my video. Okay. I couldn't open the video. Yes. Yes. No.
Hi, Professor Kamal.
Yes. Yes. We've met before in the Contrast Academy, I think, twice. Once in England and then in Italy.
That's right. Yeah.
Yeah.
Okay. I would like to ask Professor Iman Faker, Dr. Iman Faker. Are you with us? Yes, Iman.
Yes, okay.
Many questions about summarizing when to say phylloides and when to say joint fibroadenoma. I know that you have said in your lecture, but please get to the point again in simple points, because a lot of questions about this differentiation.
Okay, actually, to come to the end point, the biopsy is the crucial cornerstone for the diagnosis of both. But there's sometimes some radiological findings or imaging findings can help us to differentiate between both. As we said, the size phylloides, but it's not a something we can depend on, because as I presented in one of my cases, there was a very small lesion, and it was a malignant phyllodes. So it's like the lobular, as Dr. Sherihan mentioned. It's sometimes it's not our fault if we misdiagnose or put it under follow-up, close follow-up. Actually, after the size, the calcification are more common, the fibroadenoma. Phylloids actually are showing internal cystic spaces or cystic cliffs within, and this is a lot of the lesions show this, as we found in our cases. A lot of the cases showed this criteria. Also, we apart from the calcification size and the calcification and size, also the recurrence. If the patient, as one of the cases, performed a lumpectomy or modified radical mastectomy, and it's a in the same post-operative bed, it's more common to be a phyllodes, not a fibroadenoma. The vascularity is very important, and I always say to anyone working, we should open color Doppler in every lesion we see, because it's very crucial in diagnosis. The phyllodes shows high internal vascularity in color Doppler. Actually, the giant fibroadenoma, as it's even if it's very large, it preserve the benign criteria of vascularity, the peripheral vascularity with the central twigs. These are the main points, but it's not wrong to write in your report it's a large, probably benign or largely complex lesion. If you still 50-50 can write giant fibroadenoma versus phyllodes. We write this a lot in our practice. And the last finding, the last thing is for the biopsy. Biopsy is the crucial point for diagnosis. So you can write it this 50-50 and ask for tissue biopsy, and it will, I won't say that a lot of our cases also, the biopsy, the tissue core biopsy gives the fibroepithelial neoplasm, but after surgical biopsy, the post-operative, it gives the type of the lesion, borderline, malignant, benign. So so the biopsy is a must in these lesions.
Thank you very much, Dr. Iman Fakir. And now our last question to Professor Gilbert. I would ask about the false positive results by the MRI. Do you find the abbreviated MRI in dense breast give us the same false positive as the classic protocol? Professor Gilbert?
Yes, I can hear you. So, but I didn't quite catch the question.
Dense breast, one of the drawbacks of the MRI in the dense breast is that sometimes it gives us a false positive results.
The false positive result?
Yes.
Absolutely. That's exactly what our problem is at the moment, because you tend to get, Maxine was referring to earlier, you get this background parenchymal enhancement often, and sometimes it can be really difficult then to distinguish what's going on.
Even in the abbreviated protocol, the very short protocol?
And it's a very short, we use a very short protocol, so we're actually imaging at 1 and 2 minutes, so pre-contrast and then 2 post-contrast sequences, and we also do a T2 examination as well to try and improve our specificity. But our problem is that we tend to do, so we do screening MRI for high risk at the moment, it's full protocol, and we tend to do MRI for problem solving and neoadjuvant and all the kind of usual, the preoperative staging. And the problem is that we tend to be very, we want to avoid missing things when we're doing it for those reasons. But when you're doing screening in a only slightly increased risk group of women, we need to drop down our anxiety when we're reading the examinations. We need to stop overcall. We're kind of overcalling at the moment. I don't know if Maxine's found. Maxine, have you found that you had to kind of try and recalibrate how you're reading? It's kind of
what, from diagnostic to screening?
Yeah.
Well, It's a mix though, because the one thing that you learn with the BRCA1 patient is that little 2 millimeter or 3 millimeter thing that you see. 6 months later comes back and says, hey, now I'm a triple negative, I'm a real big cancer. So it's not easy to, I actually am more nervous about those patients than my diagnostic ones.
So I completely agree with you. It's that kind of prior, the Bayesian prior probability. So certainly with my rule is if I'm dealing with a BRCA or a 50% BRCA carrier on high risk MRI, then I'm basically calling anything that looks, 5 millimeters, and I'm even marginally worried about, because you so often get caught out. But what I'm talking about is using MRI in the kind of just slightly higher than normal population risk. And there I find it much more difficult to ignore things. And I have to keep reminding myself, this is not a high risk population.
Well, the Akron trial actually had a fairly low callback rate. I think I thought that was one of the good pieces. Again, these were women who were average risk; they were not high risk women, and so the callback rate, and especially because you look at the U.S. compared to the rest of the world, our callback rates are. I mean, I think if you remember one of the early papers from Penn where they dropped their callback rate with Tomo from 20 to 16%, I'm sure all of you fell off your chairs, said, are you publishing that you have? But truthfully, this country is so afraid of lawsuits and all of these things. But when we did the abbreviated MR study, fairly low because it was average risk. I think you just have to use everything which is the risk level for that patient.
Yeah.
And sometimes just do 6-month follow-ups, which if it's not a BRCA1, then you can take a breath because you haven't got too much to lose. One of the other things that we have started piloting in our BRCA patients is that, because they do get alternating screening, is then rather than doing a regular mammo, which for BRCA1 patients is kind of a waste of time, is in some of them we're doing contrast mammo. And so we are giving them 2 vascular studies a year. And that helps us.
Max, I think that's such a good study. We'll do that study formally with you because it's such a good idea.
I think we need to start it formally because, there's still a lot of places in this country that are afraid to use contrast for screening altogether. And actually throughout the world, I know I've been places they say, if somebody dies of a contrast reaction, I'm too nervous. But if you look at
it happens rarely, actually, the contrast reaction with contrast, it rarely happens.
0.82, Zanardo's meta-analysis of all the literature was 0.82%, and they were all mild except for
controllable. Yes. It's. I think we should be afraid of MRI because we don't see the consequences. They happen too late to see. I have a question, please. We are asking for too many second look ultrasounds after the MRI. Is this natural, or are we over exaggerating in our diagnosis?
Yeah, we're doing the same. We're doing too many as well. We're over calling.
Yes.
That's not our problem. If something is less than a centimeter, I won't bother with an ultrasound because I frankly, even if you find something, it may not be the right thing. And so anything under a centimeter, I biopsy or I follow.
Yes, the problem is that we have to look up for it for the ultrasound because we still don't have an MRI guided biopsy. So it's our main.
That's a different story.
Yes.
In order to be certified to do MRI in this country, you have to have the capability of performing a biopsy or having a place. When I was in California, I would just send them to UCLA, but that does really make you do a lot more ultrasounds. Yeah.
Yes, we're in the process of having contrast enhanced mammography guided biopsy, and we also have a PEM, the PET mammography, and I think this would be much better even than the MRI because the radio tracer stays within the lesion for several hours. So I think we'll try this. Maybe it's a good alternative to the ultrasound biopsy. Yes.
Well, again, if they're small on MR and you biopsy something, then you have to go back and do another MR because I cannot tell you how many times I've seen some little thing that looked like it might match the MR, and then you see the
Yes.
clip has nothing to do with the lesion. You should have biopsied on MR.
Yes.
Very careful.
So there are phalluses also with the MRIs.
Well, that's all with the questions. I would like to thank you all, Professor, for this rich webinar. It actually will be very interesting. Professor Dr. Maxine Jocklison, Professor Dr. Rasha Kamal, Dr. Iman Faker, Dr. Shirian Fakhri, and Professor Dr. Fiona Gilbert for your participation for the first live webinar presented by Bahia Hospital. Of course, I would like to thank Bahia Foundation for Breast Cancer Screening and Treatment, and a special appreciation for the sponsoring company, GE Healthcare, in person of Mariette Miss, Women's Health Marketing Manager. Well, thank you all very much, and have a very, very wonderful weekend.
Yes, thank you. Thank you.
Thank you very much.
Okay,
Bye.
bye-bye.
Thank you.